evening, everybody. Good evening, everybody, and welcome to the evening rounds. I'm Dr. Melinda Lukens. I'm one of the physicians here in the Department of Complex Comprehensive Gynecology, and I specialize in menopause, osteoporosis, and weight management. So today we're going to really focus on that weight management, and we're going to cover some of the definitions and assessments and treatments in this short hour we have together. So this session is part of our continuing education series for OB/GYN nurses and medical assistants. So the title of my talk today is Updates in Weight Management. And I don't have any financial disclosures. So this is a list of our objectives. So first we're going to define obesity and we're going to talk about its associated risks. Then we're going to review different ways of diagnosing and evaluating obesity. Then we're going to take a look at risks and changes throughout a woman's lifespan. And then we're going to review some management options. So the first thing is we're going to just do a definition, and this is long. This is by the Obesity Medicine Society, but I think it really well represents what truly is obesity and that it is a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass, physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. So I think the biggest thing to take home here is that this is a really in-depth definition because it is not a condition where it's, should be shamed. It is not a condition that is potentially our patients not trying hard enough. It is truly a chronic disease, and yes, it can be treated in many different ways, but unfortunately, it can relapse very easily, especially if it's not treated long term. But some more definitions that you may be slightly more aware of is a BMI. So when we think of BMI, that's height versus weight. And in the overweight category, we're saying it's a BMI of 25.0 to 29.19. And then we've got three classes of obesity. So 30 to 34.9, then class 2, 35 to 39.9, and then class 3 is greater than or equal to 40. Another way we can define obesity is by a percent of body fat. And so in women, it is somewhere over 32 to 35%. And in men, it is different that it'll be over 25%. A third way it can be diagnosed is by waist circumference. And so in women, if their waist circumference is greater than or equal to 35 inches, or it can be diagnosed just clinically, and that someone that has excess adiposity is that it's impairing their health, regardless of what the BMI is. And the thing that's important to understand here is that these are based on a certain population of women, mostly Caucasian, that our Asian populations are going to be slightly lower BMI and waist circumference cutoffs because they are actually found to have higher risks at lower body fat percentages versus our Pacific Islanders and our Black patients are going to tend to have a greater lean mass. So their obesity cutoff is actually a little bit higher, that they will have lower visceral fat at the same BMI as Caucasian people that we make these definitions at. And versus our Hispanic patients, they actually tend to have higher visceral adiposity at the same BMI and higher metabolic risk. So there's some nuance in here. These are just general definitions. These are definitions that our insurance companies are going to use for us, mostly in this BMI category is what they're looking for. But we should all recognize that these are based on certain standards, not universal for all ethnicities. And why do we care, I guess, I say this to patients every day that I care because the patient cares and they don't like how they feel or maybe look in the mirror or they don't like their clothing size or whatnot. But medically, we really care because obesity can be a marker of disease. And so there are over 60 comorbidities that are associated with obesity, and it really can affect every organ system in the body from the brain all the way down to our toes. And you can see here that I've listed out different pulmonary disease, liver disease, gallbladder disease, gynecologic abnormalities like abnormal periods, infertility, PCOS, polycystic ovarian syndrome, and then heart disease, pancreatitis, different cancers relevant to us, increased risk of breast, uterine, colon, and even ovarian has some links with obesity. And then, of course, changes in our blood flow, increasing our risk of phlebitis or venous thromboembolism too. But interestingly, people who are obese, unfortunately, are 2 times as likely to have high blood pressure. And a high BMI accounts for nearly 1 in 10 cardiovascular disease deaths. MASLD is a really big word. It stands for metabolic associated steatotic liver disease. The old name that we used to use that we're getting away from is called fatty liver, but unfortunately it's present in 60% of patients with obesity. And unfortunately, this is an inflammatory condition that can lead to liver disease, liver cancer, liver failure over a course of years. 50% of women with PCOS are overweight or obese, and 43% of type 2 diabetes is attributable to obesity. And another really interesting fact is that 70% of people in pre-diabetes range will go on to develop type 2 diabetes. And about 50% of those with obesities will also have obstructive sleep apnea. Specific to us and OBGYN, why does obesity matter? Well, unfortunately, the percent right now is that roughly 36.5% of US women aged 20 to 39 have obesity. And from just 2016 to 2019, the pre-pregnancy obesity increased from 26.1 to 29%. And women with obesity are more likely to have infertility, take longer to conceive, and have higher rates of hormonal disorders like PCOS. And when they are able to get pregnant, if they are able to get pregnant, we know that they have increased risk of gestational diabetes, preeclampsia, cesarean delivery, large babies, and difficulty with ultrasound visualization so we can miss fetal anomalies more often. And actually, there's some data to show that unfortunately, when we're obese in our pregnancy, we are imprinting our newborns for them to be at higher risk for obesity during their life in these diseases. And as we age, unfortunately, the picture doesn't get that much better. In women aged 40 to 59, about 47% have obesity. And women, unfortunately, have a higher prevalence of the severe obesity with that BMI greater than 40 than men. It definitely costs the US health system a lot of money, about $173 billion a year. And it, like we said earlier, is associated with an increased risk of cancers. And of course, it will decrease mobility with the increased risk of arthritis and joint pain also. And in menopause, we do see a critical relationship between aging and metabolic health. It's a really big time period to help to intervene with stabilizing people's weights and helping them with weight loss. Age-related weight gain in midlife is very common. The average weight gain can approach 1.5 pounds per year normally. It can be even more. And in menopause, we do see body composition specific changes. So that menopause transition can increase our visceral fat more. It can decrease our muscle mass, and that conversion from our muscle mass to body fat really does increase, which then will show an increase in that waist circumference. And that, oops, sorry, and that will actually show a direct link to increase atherosclerosis, which is where the cholesterol gets deposited into our arteries, and especially in the carotid arteries, the neck arteries. And we'll see lipid profile changes that within the first year of the final menstrual period, that we'll see an increase in their total cholesterol and their LDL, which is the bad cholesterol, also the apolipoprotein B, which is a dangerous cholesterol. And we actually can see that the HDL, which we think of more protective, will not be as functional in protecting our overall cholesterol stabilization, that it can start to not work as well to protect us. And so these metabolic impacts, we really see that they're going to be increased in that time of transitioning into menopause. And those that unfortunately go through menopause early, in their earlier 40s or even younger, will have a compounded risk of this. And there's many factors that go into this, aside from just how our body is changing internally. But one of the big things that we see is that our physical activity is going to decrease. And our nutrition, maybe we aren't paying as much attention to it. And an interesting statistic, unfortunately, is that only 7.2% of midlife women meet the recommended physical activity requirements that we recommend for overall health. And less than 20% are maintaining consistent healthy eating patterns. So this is really a time that is vulnerable for the period of weight gain, and a critical window for our cardiovascular health intervention. So what are the best tools for measuring obesity? I kind of mentioned this in that earlier slide, but just let's talk through kind of what is the difference. So that BMI is the height versus weight. So we're going to measure their height, or ask them what their height is, and then we're going to weigh them, and that's going to calculate in Epic what is their BMI. And it's easy, it's fast, there's universal cutoffs there, but the limitation of it is it's not going to tell you what's body fat versus muscle, and it's not going to tell you how much is visceral fat. So there's certain people, based on their body type or their ethnicity, that they're going to have higher muscle mass, and so their BMIs are going to be higher. So they may look like they're in the overweight category, or in the low rate of obesity based on their BMI, but it's really that they have this large muscle mass. But by and large, the BMI does do a fairly good job of estimating those higher body fats as those numbers go up. Our waist circumference, it is a little bit better at telling us what's our risk of visceral fat than BMI alone. It's very inexpensive, but it does vary by what sex somebody is or their ethnicity, and it is technique dependent, that we have to make sure that we're measuring their actual waist circumference at the best spot versus their hip circumference. And then those of you who have worked with me in the DCAM clinic, or out in our suburbs, Hinsdale and Northbrook, we have the InBody, which is a body composition machine, and that is a little bit more accurate. That it's going to tell us how much of somebody's body weight is in muscle mass, how much of it is in body fat, how much of it is in visceral fat. It does vary by hydration. So what it is it's not, couldn't find a really great picture to put on the slide, but the people stand with bare feet, as light of clothing as possible, and their hands on the handrails. You guys might have seen these in gyms or different places will have these. And they hold on with their thumbs, and it basically is sending little electric currents through that body to look for water. So our muscles, our organs, our bones, they contain a lot of water. Our body fat is more like an insulator. So it kind of marks, okay, where's the water? Where is the muscle versus bones versus fat. essentially. So it's going to vary by hydration. So if somebody has drank a bunch of water before they came in, it's going to vary a bit. If they are more inflamed, maybe they have edema in their feet, it's going to pick it up a little bit different. Or if they have a full bladder, that's another thing. So the best is to come in sort of fasting in the morning as light up clothing. If we could have no clothing, maybe even better. And but I really like using my InBody to sort of shift the focus off of the scale and somebody's weight and more onto the like, okay, how much of this is muscle mass, which is great, and how much of this is more body fat or visceral fat. Because I think a lot of people are triggered by a weight. So this helps to move the conversation around a little bit. The gold standard is something called a DEXA scan. So you guys might have heard of a DEXA scan that we use for bone density. So we're looking for osteoporosis with that. Well, we can also use the right machines if it's calibrated correctly for body fat. That's going to be your gold standard, and it's going to tell you the most accurate measurements. But it's really expensive. It's not usually covered by insurance to do it for this reason. So I haven't adopted that as one of my regular ways to use in my practice. So when I see a patient, we're going to get their basic vitals. We're going to get their body, and then we're going to assess their overall health, what medications they're on, what might be contributing. And then I really try to dig in for them this concept of the 4 pillars of weight loss. And so we really want to think about each of these things as critical to stand up the building, right? And so I always focus on the first 3, that we need to optimize nutrition. We need to optimize our movement, and we need to optimize our behaviors, which the behaviors include our sleep, how we are managing stress, how we are talking to ourselves, how we are, if we have depression or anxiety, if that is managed, and how we are using food as potentially a tool to manage those different mental well-being factors, because sometimes we've created food as a medication to help treat some of these other disorders that are going on. And so I try to help them understand that the medication is really a tool in the toolbox to help even the playing field for those with the disease of obesity, with the underlying metabolic dysfunction, maybe genetic predisposition, but truly cannot hold up the building alone. It's not in substitution of those other 3. And if they don't optimize the other 3, they will not see the success that these medications can bring for them, and actually can have a lot of side effects with them. So I think it's really critical that we try to build this comprehensively and let them understand that, like, we really want to use this medication to prop those other 3 pillars up tall. And here you can see, if we really dig into behavioral modifications, which is going to be diet and exercise and sleep and behaviors and all of those things, we can help people lose up to 10% of their weight. And that can be really great, and they could potentially do better than that. But what we know, going back to that initial slide, is that this is unfortunately a relapsing and unrelenting disease. So a lot of people will lose and then regain, and that can be really, really frustrating. So then we see our older medications come into the picture, which is things you may have heard of: phentermine, Qsymia, which is a combination of phentermine plus topiramate, Contrave, which is a combination of naltrexone and bupropion, orlistat. These are older medications that have been around a long time and can be helpful in the right patient for the right reason of what is making it difficult for them to lose weight. And it can help people lose up to 11% of their body weight. And what happened a few years ago is that the GLP-1s, so to speak, entered the scene. And why that really changed the landscape and the conversation, and why they got so much attention, is we did start to see that average total body weight loss jump up from those lower levels where we were at with the older generations and with diet and exercise alone, up to as high as 22.5%. And I've seen even more than that if people are really optimizing all of those pillars in coordination. And to where we're starting to approach the outcome of bariatric surgery, which is, of course, something I always talk to patients about, not something I do, but that I want to make sure that they're really well informed about these options and how the average body weight loss is higher, up to 35% in the literature for the gastric bypass or the sleeve, et cetera. And you might ask yourself, why bother with weight loss that's modest, it's only 5 to 10%? Well, because all weight loss is good, and truly we can see improvements in our cholesterol and other cardiovascular risk factors, reductions in blood pressure, improved insulin sensitivity, and reduced likelihood of progression from that prediabetes to type 2, even with just a 5 to 10% weight loss. So I never want somebody to be discouraged by that. I want them to be empowered that. But if we get greater than that 10%, we will see further improvement of those above disorders. We will see reversal in that MASLD, that fatty liver disease, and that decline in liver function, and significant improvement in sleep apnea, joint pain, other arthritis conditions. And in the fertility world, we will see improvements in polycystic ovarian system syndrome and fertility. So I'm sure that you guys have had a lot of patients or maybe friends or family members or even yourself ask this question, like, who is a candidate for medication? And what my definition is may be different than our insurance companies. And there are different ways, like I showed you in those other slides, to diagnose obesity. But truly in the insurance world, as it stands now, and it could change again, is that it's those who have not met their weight loss goals of at least 5%, about 3 to 6 month mark with comprehensive lifestyle interventions. And again, that depends on the insurance company and what they say. Some insurance companies will say a year, and they have a BMI greater than or equal to 30. Or if their BMI lands between 27 and 29.9, that they have another weight-related comorbidity, such as cardiovascular disease. And that is that they've had a heart attack, a stroke, stents placed, bypass, et cetera. High cholesterol, high blood pressure, sleep apnea, liver disease, chronic kidney disease, type 2 diabetes, and PCOS. I've even seen arthritis fall on that list sometimes, but truly, that's when I've seen all these different games that these insurance companies are playing, unfortunately, lately with this. And now sometimes they're saying, okay, you have to have 2 or more of those related things. And a lot of times, even if people meet criteria medically, their insurance has opted out, or their employer has opted out of covering these medications at all. And so I just thought we'd take a few more minutes to delve into, like, what are the 2 most common medications that people have heard about, that patients may be asking for, looking for more information about, do I qualify for? And the 2 are Zepbound and Wegovy. So Zepbound is semaglutide, and I'm sorry, tirzepatide, and the diabetic one is called Mounjaro, and then Wegovy is semaglutide. The diabetic one is Ozempic. So very confusing words, but the semaglutide is Zepbound, and I'm sorry, tirzepatide is Zepbound, and semaglutide is Wegovy. So they both have different FDA indications. So if somebody has moderate to severe sleep apnea and obesity, they can qualify for Zepbound, versus if they have had cardiovascular disease or moderate to advanced MASLD, they may get that medical indication for the Wegovy. Zepbound seems that there is slightly less severe nausea related to it, but they can have more diarrhea reported, versus the Wegovy can have more acid reflux, more burping, and potentially more constipation on that side. And that just brings me to the next slide, which we're going to talk about common side effects. But the Zepbound only comes in injections so far, and that is weekly. The Wegovy comes in daily oral now or weekly injections. And this is a list of common side effects. The most common are, and going to be dose dependent, are going to be GI, nausea, vomiting, diarrhea, constipation, bloating, acid reflux. Okay, so how do these work? So basically, these receptors for these medications are called GLP-1 receptors. The tirzepatide also binds to something called a GIP receptor. Most of those are in our GI system. So they're in our stomach, our small intestine, our pancreas, also in our brain. So how they work is mostly that they decrease the emptying, they slow down the emptying of the stomach and the small intestine. So it makes sense that a common side effect is going to be nausea, acid reflux, constipation. It's going to reduce appetite. That's the point mostly of how it works. So of course, that's a common side effect. Some people will report altered taste, that things just don't taste as good or sound as good anymore. It can slightly drop people's blood sugar. If somebody's not a diabetic, it's probably not overall going to change their blood sugar. But if they are diabetic, they have to stop their other diabetes medicines when they, like oral medicines, when they start these other than metformin, because it can really drop their blood sugar. Dehydration is quite common. So it's something that I talk a lot to patients about, because food has a lot of water in it. We underestimate like how much water is in food. So if you're eating less, you're going to intake less food. I'm sorry, water. And also, it decreases your drive to drink too. So we need to make sure that people are getting enough water. I talk about 64 ounces of water a day. You can get some redness, some swelling, some itching at the site. A concerning thing would be significant gallbladder issues, so like a gallbladder attack or pancreatitis. Those would be not so common, but those would be the more severe things that would lead us to need to potentially stop the medication. Fatigue is fairly common. Hair thinning is another one. It's probably not the medicine that's causing hair thinning directly. It's more nutritional, that people are eating less and maybe not eating as much nutritional foods as they need to decrease that. But by and large, the hair thinning is transient. That means that it is short-lived. That is, people can improve their nutrition, make sure they are eating enough and enough proteins and fruits and vegetables, that their hair growth will regrow. And so I sort of alluded to in the prior slide, but there are some patients who cannot use these medications. So that's going to be somebody who has a history of pancreatitis, which is inflammation of the pancreas. Somebody that's had something such as gastroparesis. So that's a disorder that can stand alone, but it's more common in diabetics where their stomach is not emptying properly. If they have active gallbladder disease, then they need to get that treated. A big one for us in OB-GYN is you cannot take this in pregnancy or if you're trying to become pregnant. We don't have any data to show safety in pregnancy. So we have to make sure that our patients are on adequate contraception. And if they have an accident and become pregnant, they do need to stop it right away. If they are considering a pregnancy, ideally it's stopped at least 2 months prior to attempting. If there's a very strong family history or a personal history of a rare thyroid cancer called a medullary thyroid cancer or a syndrome called MEN, if somebody has diagnosed diabetic retinopathy, eye disease, if they have severe renal impairment, kidney impairment, that they could be prone to dehydration, that is a problem. If they have had suicidal ideation or uncontrolled major psychiatric illness, I don't mean a history ever of suicidal. I mean, if they're having active suicidal ideation or have a major untreated psychiatric illness, this is not something that I'm going to start on them in that time until they get that under better treatment. And as I said earlier, if they are on insulin or certain oral diabetic medicines such as sulfonylureas, they have to stop them because they can get very significant hypoglycemia. So the next question that comes up really commonly is, okay, am I going to be able to stop this? What happens if I stop this in the future? And what I tell patients is we have to remember that these medicines are meant to treat the disease of obesity. And what we understand is that obesity is a disease by and large. And so most patients, if we're not treating the disease, they're going to have rebound weight gain. So in the two big studies we have of the two medicines, the tirzepatide, which is Zepbound, and the semaglutide, which is Wegovy, they really saw a significant weight regain within 1 year. With the tirzepatide or the Zepbound, they saw a 14% regain within 1 year. So those that stayed on it for the entire time, they lost almost 25%. Versus if they got back off of it, they ended up only losing 10%. And in 3 years, when they extended this trial, they saw full weight regain. Even before their weight came all the way back, we saw a rebound in their blood pressure and their cholesterol and their prediabetes and all of that. And so the same was true with the semaglutide. So we really want to think of these as therapies that somebody may need for a lifetime. And I tell patients that I don't know if it's this medicine, because the beauty is that this field is exploding in research and medications are going to be coming down the pike. And so there may be something different in the future that we will transition to once they're in a maintenance phase. But at this moment, these are the two that I have to work with. So how do you guys come into it as our nurses and our medical assistants? You know, in my clinic, my medical assistants are going to assess the patient's vitals, to perform their in-body, to talk to them about what symptoms they're having so they can relay that to me or my nurses. My nurses, by and large, are going to be helping me with getting their prior authorizations through with their insurance, and if they need appeals, because a lot of times the insurance wants to deny these things, even though the patient meets the right criteria. Help assess side effects when patients come into the clinic or are emailing, help to guide them on proper hydration and nutrition. And then when we're titrating their medicine up or down, just helping to guide them on when that might be the right time, of course, with my help. So I hope that was informative, and I am ready to take any any questions that you guys may have.
I have a question, Dr. Lukens. How do you manage patients who don't fit criteria but want medication because let's say they are minimally more, it's 5 pounds maybe we'll give them 10 pounds. They're not in the overweight range. There's no health implications of it, but they are stressed about the slowing down of metabolism as we get older and want to be on something to help them take that middle bulge off that they have now.
Yeah, that is a great question, Dr. Christmas, and something that I deal with quite a bit, as you can imagine. That I really try to talk to them about that this is a medication and it has an indication to treat the disease of obesity. That's really not meant to just help us to fit into, a certain dress for an upcoming event like a wedding or a graduation or, whatever it is. And that it does have consequences of starting and stopping, and also it's not indicated unless you truly have the disease of obesity. And so I really talk to them about this isn't in substitution of those other three pillars that I said before. And so I really help them to refocus into what can they do in their nutrition, in their movement, in their behaviors to help to manage this.
And then along the same vein, microdosing. What I
Yeah.
hear so many people, but I'm only microdosing it, and I've gotten it from some online place that is compounded, so it's not even like a government approved version of the medication.
Well, I could do a whole talk about. But so first of all, there is no sort of medical guidance on like this microdosing term is not an actual scientific term at this moment. And I don't know if there will be in the future, but for my goals, whenever somebody gets to their goal health status, goal weight, then I try to get them to the lowest effective dose to continue to meet their goals or maintain their goals. And so, you know, there is no science evidence research to show that there is such thing as microdosing for those people that want to just lose that 5 to 10 pounds, that there's safety in that, that there's no repercussion for their metabolic health, their pancreas working properly, their insulin working properly when they stop it. So I really try to talk to them about that. That's really a made up term through influencers, social media, and people that are not practicing evidence-based medicines, maybe med spas or sort of off-the-cuff medical facilities that may not be true medical facilities. Compounding is a whole nother ball of yarn that there is no regulation for compounded medications that, the true medication, the tirzepatide, the semaglutide, they are patented. And so that means that there is no generic version of those two medications. And so when somebody's compounding it, that means that I try to explain to the patient, that means that they are making it in their own pharmacy, and there is no regulation to tell you like what is the quality of the ingredients that you're getting, what is the true quantity of the ingredients that you're getting, um where are they getting the active ingredient from, um and the safety of that. And there's truly no oversight. So people get a little bit nervous about, oh, big pharma, and it just is a lot of money in that industry. That's true, but there's also a lot of regulation that's safety monitoring for us as patients.
Okay,
Does
Dr.
that
Lukens,
answer
there's
your
a
question?
question. Oh, sorry.
I was going to tell her that, Jan. Yeah, Patasha had an excellent question. She asked, what is the recommended exercise plan for women trying to lose weight for long term? And what type of meal plan should they be on for the lifestyle change? I think this is excellent. I spend a lot of time as well counseling in clinic about this.
Yeah. So exercise recommendations, the overarching recommendation is that we have 150 minutes of moderate to vigorous activity a week. And so, that can be broken down a multitude of different ways, but I think the overarching recommendation on that is 30 minutes, 5 minutes, 5 days a week of moderate to vigorous activity. And the most recent studies really showed the most benefit are when people split that time between cardio and strength training or resistance training, that we don't just anchor into one or the other. So that's really the guideline. And what I tell patients, if they're like, man, that's a lot, I don't know how I would fit that in, I say start somewhere. So start by getting your steps above 5,000 every day. If you are having less than 5,000 steps in a day, you are sedentary. Full stop.
Uh,
So the minimum is to get above 5,000 on your steps every day. 7,000 or greater is good. Is that moderate to vigorous activity? I mean, you get to be the judge if it gets your heartbeat up and you get because that's your exercise and that's how you utilize it. I think that's acceptable. And then for strength training, I tell people start at 10 minutes 3 days a week. Start somewhere, right? Start at 5 minutes 3 days a week if that's all you can do, and build up. But yeah, that's sort of the guideline by and large. And then um, the meal plan, there is no specific meal plan. There's really good research to show that there's no difference in if you do keto versus paleo versus whatever fad is going on. It's really about calorie reduction. And so it's to eat within the recommended amount of calories for your age, for your height and weight, for your if you're a female or a male. It's different for all of us what that is. And truly, that is what the difference is in those studies. It's not a specific meal plan. So I try to tell patients it's about getting back to the basics, to have as healthy a food as possible, more whole foods, more whole proteins, less processed foods, less on-the-go foods, more fruits and vegetables. I talk about filling your plate to make a rainbow out of it, right? The more colors on the plate, the more vitamins that are in that plate. Unfortunately, our US diet has just so much processed food in it. And I'm not even just talking about going out to eat, but yes, cooking more at home, meal planning, having more full whole foods, less processed foods. That's going to be the key. And decreasing your calorie intake, which is individual on what those needs are, and decline with age.
I know. Do you find that many patients aren't aware of what healthy whole foods are? And then
Yeah.
I guess on that, do you have resources that our MAs and nurses could share with patients before they get the appointment with you while they're waiting?
Yeah, and so there is, we have now a nutritionist within our department. Her name is Jennifer Martin, that any patient can be referred to by any provider. I think Dr. Christmas has utilized her quite a bit. Of course, I utilize her myself, and she is just a wealth of knowledge and information. So getting patients in her hand, she sees patients in DCAM with me and Hinsdale, Northbrook, and then she has a very large telehealth presence as well. So that's one. There are all kinds. Sorry, I wasn't prepared for this question, but I should have been. But there are some really nice web resources on the internet, like plate.gov is a pretty good one. There's some, and I can get this back out. I could send out an email where we can distribute this better because I don't have it in front of me right now. But there are some nice resources that are online and talk about different healthy eating. And it breaks it. There's one that even breaks it down to different ethnicities, because everybody's food pyramid might be a little different depending on what their ethnicity is and what the, core of what types of foods they like to eat can be.
A patient just shared this app with me that I downloaded on my phone called Yuka, Yuka.
Another
It
one.
is so cool. Like literally, it's free too. They might have had a version you could pay for as well. Well, they do have a version you can pay for, but I got the free one. And when you're in the grocery store, you literally just hold your phone up on the QR coded things and it tells you like on a scale. And they do beauty products too, of
Hmm.
like basically how healthy it is or how like how many artificial things, how is it highly inflammatory, whatever. But I thought this was really cool to
That's cool
able
for
to
a free
analyze.
one. I've seen that within one of the meal tracker apps I've utilized. It's called Plate AI. And you can snap your plate, with a picture, or you can barcode, and it will also grade the food in that. But that is a paid subscription. I think it's like $10 a month or something like that. But that's a really nice one too, and a way that people can track their intake without like measuring and weighing everything. So,
I have a question. I wanted to ask, with breastfeeding, can they do the GPLs with the breastfeeding? And if so, how does it affect their breast milk?
that's right. Yeah. So there is no research to show safety. Currently, we do not recommend to use these in breastfeeding. Now, there is some evidence that these are very large molecules that don't enter the breast milk, so they shouldn't affect the infant if somebody's on it. But that said, again, like there just isn't the science or evidence available for us to say that it is safe. To your point, that we don't know what is the change in their breast milk production either. Like, let's say it doesn't get into the breast milk, we don't worry about the baby, but is that going to affect their milk production or even like the the fat content of the milk, those are questions we do not have the answers for. So the current guideline is you cannot utilize these in pregnancy or breastfeeding. Great question.
Oh, thank you. So so if they're breastfeeding and how soon after, if someone asks,
They can start it
can they,
immediately when they finish breastfeeding.
okay, right away or?
Yeah. Mm-hmm.
Oh, okay, okay. All right, thank you. Okay.
Yeah. Yeah. I mean, there are some people that are saying like there's enough evidence to show that it doesn't, enter the milk supply because of the size of the molecule and that, we have some preliminary evidence that there's safety. And so they will let people take it, based on a patient physician conversation. But I would not because there just really isn't evidence to show safety. And you don't have a leg to stand on if something happens to that baby. So.
Exactly. I was just curious. Yeah.
Yeah, no,
Okay.
awesome question.
Thank you. Mhm.
Yeah, and the problem with, these medicines in patients that want to get pregnant, they want to lose weight before they get pregnant. I didn't have the slide in here that I've used with physician talks in the past, is that we can see improvements in fertility, in the ability to get pregnant, and treatment of PCOS, related fertility issues. So with these medicines, we can see people get pregnant more often, but because of the weight regain that's involved in it, we have not seen improvement in pregnancy outcomes in the studies thus far in those that have taken these medications prior to attempting pregnancy. So that's unfortunate because, we have to tell these patients to stop it as soon as they become pregnant, and we see those pretty significant weight rebounds.
Mm.
Yeah, and then, there's not a lot of ability to do studies in pregnancy, right? And it's not ethical.
Mhm.
So I don't know
Right.
if and when we're going to have that data.
Mhm.
Right now, if you have any patients that do become pregnant on these, they do have registries available through both of the Eli Lilly, the pharmaceutical company for tirzepatide, and Novo Nordisk for um, semaglutide, that they are collecting, long-term outcomes for the pregnancy and the baby, to see, if we can get any of that information without doing a randomized controlled trial, which is clearly unethical. So.
Mm. Mm, okay, thank you.
There's another question in the chat. What are your thoughts on the pill versus GLP-1?
Yes, versus the injections. Yeah. Okay. So the only pill we have right now, and there'll be more because this field is exploding, but is the semaglutide oral pill, which is Wegovy. And so the preliminary data, well, the early data that we have, because this is a brand new, just as of January, is that it is effective for weight loss. It is not as effective as the injections. So injections, so these medications are called peptides. And so peptides are proteins essentially. And so our stomach really digests them quickly. And so not much is going to get absorbed. And so the drug company Novo Nordisk, they figured out how to encapsulate the semaglutide so that it can be absorbed a little bit more readily through the stomach. But it cannot have the sustained absorption that the injections have because of the stomach acid, essentially. And so I showed you the data of the injectables. We see upwards of 20% weight loss. With the pill form, they've seen closer to 14% on average. And that's going to be at your higher dosages. So it starts at a 1.5 milligram dosage. And, if you tolerate that, then in a month you go up to 4 milligrams. But the true weight loss has not been seen until people get to the 9 milligrams. That's the third dose. And even some people, not until if they're able to tolerate, to get to the 25 milligrams, which is the highest dose, the fourth dose. So, it's a nice option for people who can't afford the injectables. because it's cheaper than the injectables. If people have a cash pay, if insurance doesn't cover it and they do the cash pay, the pills start at $150 a month versus the injections are between $200 and $300 a month to start um, in those lower dose categories. So it's more affordable. Or for people that are fearful of injections.
Okay, there's another question. Does EPIC currently account for physiological differences between ethnicities when calculating BMI? If
Mhm.
not, is there an alternative reference that the providers refer to?
Yeah, no, that's the limitation of BMI for sure. And so the only one that we have actual different guidelines that we know we can follow is going to be in our Asian population, that their BMI, they're considered obese, and don't quote me, I have to look back at my slide because I don't have this memorized, but is lower, I think, at a BMI of 28 instead of 30, and the waist circumference a couple centimeters smaller than that standard. But it's more that in the research we do see that certain ethnicities will have less disease at higher BMIs than others, and some will have more disease at lower BMIs than others. And so there's something there in the epigenetics that we don't totally understand. And I think some of that is based on muscle mass and body type, which I didn't really get into in this talk, but there's different body types. And so um, I don't want to be overly general here, but in the research that we have in our Pacific Islanders or in our Black ethnicities, we will see that those have higher bone mass, muscle mass, which will look like their BMI is then higher than the Caucasian standard. Unfortunately, a lot of lab values and standards that we use are not universal. So I don't have like a standard go-to. It's more of a memorization understanding too. And not every physician understands all of that either, but hopefully that's helpful.
Are there any other questions for Dr. Lukens?
Well, it's been a pleasure to talk to you guys. I'm hoping that this was helpful. Um, Let me just remember this really quickly. Um, so let me just pull back up my slides. I'm so sorry, you guys. Um, okay, so in conclusion, um, this is the end of the evening round session, and I hope that this information was valuable and applicable to your work in the clinic and beyond. And mark your calendars for the next evening rounds, which are going to be held on April 6th by Dr. Fisher, and the topic will be first trimester bleeding.
Thank you, Dr. Lukens.
Thanks, everybody.